of the Philippine Association of Pancreatobiliary Surgeons. This is in partnership with Medtronic and Telemedicine Network of the Philippines. For the participants, I hope you were able to answer and submit the pre-test for this webinar. Okay, so as we gradually try to return to the normalcy of our practices, we will be gearing a little away from webinars on COVID-19. Tonight's presentation is entitled Decision Making and Tailored Management of Gallbladder Cancer. So this will be a thorough discussion on gallbladder cancer, from its biology, histopathology, diagnostic imaging, management, and adjuvant therapy. So sit back, turn up your volumes, and let us all together learn from the comforts of our home. To start the program, may I call on Dr. Raymond Joseph De Vera, HPB Fellow at Rizal Medical Center, to lead our opening prayer.
Allow me to read from the book of Psalms. I will lift up my eyes to the mountains. From where shall my help come? My help comes from the Lord who made heaven and earth. He will not allow your foot to sleep. He who keeps you will not slumber. Behold, he who keeps Israel will neither slumber nor sleep. The Lord is your keeper. The Lord is your shade on your right hand. The sun will not smite you by day, nor the moon by night. The Lord will protect you from all evil. He will keep your soul. The Lord will guard your going out and your coming in from this time forth and forever. Psalms 121. Lord, we come into your presence with thanksgiving, for you are our refuge and strength. You are our source of true peace, the rock of our salvation. You, O Lord, are a great God, a great King above all gods, the King of the universe. In your hands are the depths of the earth. The peaks of the mountains are yours also. The sea is yours, for you are the one who made it, and your hands formed the dry land. We worship and bow down. We kneel before you, the Lord our Maker, for you are our God, and we are the people of your pasture and the sheep of your hand. Lord Jesus, forgive us for our sins. Thank you for dying on the cross to save us from our sins, and that you rose on the third day to reign forevermore. Lord, we thank you for gathering us tonight in this online webinar to learn from our colleagues, mentors, and leaders in the field of HPB. We thank you for the gift of technology. We thank you for the organizers, sponsors, panelists, speakers, and guests. We ask for the success of this activity, that you may be glorified in it. Grant us good internet connection, deliver us from technical difficulties, open our minds and give us understanding to learn from our speakers. Give us wisdom to apply it in our practice. Use us as your instruments for blessing and healing as we serve our fellow countrymen. Keep us all safe, especially in these times of pandemic. Protect us from sickness and harm. Guide our national leaders in their decisions. Grant us good health. May you also provide for our needs. This we all ask in the mighty name of our Lord God and Savior Jesus Christ, to whom belong all dominion and power. Amen.
Amen.
Amen. Thank you, Dr. De Vera. To officially welcome us to tonight's webinar, may I call on the ever-energetic, may it be on the physical or virtual world, the President of the Philippine Association of Pancreatobiliary Surgeons, Dr. Catherine Te.
Thank you, John. Good evening, everyone, and it's really nice to have all of you here joining us tonight. As you know, HPV diseases, especially cancer, requires a multidisciplinary approach in its management, and patients benefit best in this manner. So tonight, our CSE committee has worked really hard preparing for this topic, and for us to discuss a sensational topic that is interesting to most surgeons and other physicians like radiology, pathology, and even oncology as well. And what's more important is that we're very lucky to have with us tonight an excellent panel of experts, not only locally, but also we have with us Dr. Anil Agarwal from India. Anil, thank you for joining us. And Anil is an authority in gallbladder cancer. As you know, gallbladder cancer incidence is very high in India. So we are very lucky to have him on board as well. So this is just the beginning of our PAHPBS online learning series, and we strive and commit to bring you quality content relevant to your daily practice. So in the next couple of hours, let's listen to our speakers and learn from them and learn from each other as well. I'd also like to thank Medtronic and of course TNP for always supporting our endeavors. So John, take it away.
Thank you very much for that warm welcome, Dr. Te. So just to remind the participants of this webinar, we will be having a total of 6 lectures. If time permits, we will have a Q&A segment at the end of all the lectures. No? So please direct all your inquiries and comments at the Zoom Q&A and chat boxes. No? Our panelists will try to answer all your questions via chat or on air. May I also please remind everyone to answer the post-test and evaluation at the end of the webinar. So shall we proceed with our lectures? For our first speaker, she is a graduate of Xavier University, Dr. Jose P. Rizal College of Medicine. She had her surgical residency training at Northern Mindanao Medical Center and did her fellowship on hepatobiliary and pancreatic surgery at Seoul National University, Bundang Hospital. She is currently a medical specialist 3 at Amay Pakpak Medical Center in Marawi City and a general surgery faculty at Xavier University, Dr. Jose P. Rizal School of Medicine. Ladies and gentlemen, may I introduce to you a hero during the Marawi siege, Dr. Hanisa Guro.
Good evening, doctors. First of all, I would like to thank the Philippine Association of HPB Surgeons for giving me this to be part of this webinar. It's really an honor for me. It's raining here, so maybe you can hear the rain. All surgeons who treat gallbladder disease must understand the natural history, biology, imaging, staging, and proper surgical treatment of gallbladder tumors. Tonight, I was tasked to talk about gallbladder cancer biology and its staging. Gallbladder cancer, although rare, is the most common of biliary tract malignancy and the 5th most common among malignant neoplasm of the digestive tract. It traditionally has been considered as an incurable disease with an extremely poor prognosis. The nihilism historically associated with gallbladder cancer stems from its late presentation, often with disseminated disease, overall dismal prognosis, and lack of effective systemic therapy. Gallbladder cancer has a tendency to spread early via lymphatics, hematogenous, and peritoneal metastases, and also has a unique ability to implant along biopsy tracts and wound. The overall 5-year survival rate, according to reports of gallbladder cancer, is for resectable disease, 20% median survival of just 16 months, and for advanced untreated gallbladder cancer, the median survival of 2 to 5 months. Long-term survival is exceedingly rare. For the epidemiology, the global incidence of gallbladder cancer varies significantly by geographic region and racial group. It affects women 2 to 4 times more than men. This may be related to the higher rate of cholelithiasis and inflammation in women. The incidence increases progressively with age, both in male and females. It is most commonly diagnosed in the 7th decade of life. The highest incidence of gallbladder cancer is found in Chilean Mapuche Indian women, followed by women living in India and then North America. Here in the Philippines, it ranks at 22nd of the most common cancer and has an incidence rate of 0.63%. This is according to the International Agency Research for Cancer. Throughout the world, there is no consistent trends in the incidence of gallbladder cancer, with modest increases and decreases reported in cancer registries from various countries. The most consistently implicated etiologic factor in the development of gallbladder cancer is cholelithiasis. Of gallbladder cancer, 75 to 90% occur in the setting of cholelithiasis. It has been suggested that larger stones have a greater impact on the risk of developing gallbladder cancer. The higher risk of gallbladder cancer development in larger stones possibly reflects the greater duration and intensity of epithelial irritation. The presence of calcification on the wall of the gallbladder, otherwise known as porcelain gallbladder, also is a condition associated with higher risk of gallbladder cancer. It is associated with carcinoma in 12.5 to 62% of patients. The calcification is likely the result of long-standing inflammation. Anomalous pancreatobiliary duct junction with a long common channel between the pancreatic duct and the bile duct has been associated independently with gallbladder cancer risk also, and may be related also to chronic inflammation. The anomalous ductal union is seen in 17% of patients. APBDJ is not under the control of the sphincter when outside the duodenal wall. Therefore, pancreatic juice can freely flow back into the gallbladder, causing bile stasis, which then leads to precancerous changes in the gallbladder mucosa. The presence of polyps is also another predisposing factor for carcinoma of the gallbladder. Recent evidence suggests that polyps larger than 10 millimeters in diameter have greater malignant potential. The incidence of malignancy in gallbladder polyps is higher in patients with primary sclerosing cholangitis. Some chemicals have also been implicated in gallbladder carcinogenesis, including methyl dopa, oral contraceptives, isoniazid, and occupational rubber industry, but none of these associations have been proven. Epidemiological studies have also shown that there is a strong association between gallbladder cancer, obesity, and estrogen. Typhoid infection has also been associated with increased risk of this tumor type. Segmental adenomyomatosis of gallbladder, chronic inflammatory bowel disease, and polyposis coli has also been linked to the carcinoma of gallbladder. Now we go to the anatomic considerations. It is important to understand the anatomy of the gallbladder, the biliary tree, liver, and hepatic hilum to manage tumors of the gallbladder properly. The gallbladder is a hollow pear-like shaped organ that lies on the cystic plate under the liver segments 4B and 5. It primarily functions as a reservoir for bile. The gallbladder is a partially intraperitoneal organ structure. On the side of the gallbladder that is attached to the liver, there is no peritoneal covering, but there is a fibrous lining known as the cystic plate that occupies the space. During simple cholecystectomy procedure, the plane between the muscularies of the gallbladder and the cystic plane is dissected, which is an inadequate resection for malignancy involving the gallbladder. The gallbladder varies in size and composed of the fundus, the body, infundibulum, and the neck. The fundus usually, but not always, reaches the free edge of the liver and is closely applied to the cystic plate. Most cancers originate from the fundus at about 60%. The body is medial to the fundus, which is embedded in the gallbladder fossa of the liver, and 30% of gallbladder cancer originate from the body, while 10% originate from the neck. The arterial supply of the gallbladder is via the cystic artery, which is the branch of the right hepatic artery. Venous drainage is from cystic veins. Venous blood from the gallbladder drains into the segment 4 of the liver by short direct communicating veins accompanying the extrahepatic ducts into the liver. It has been postulated that hematogenous metastases originate from these small veins extending directly from the gallbladder into the portal venous system of the gallbladder fossa. For the lymphatic drainage from the gallbladder lead first to the cystic and pericholedochal nodes. From these nodes, the primary drainage areas are the retroportal and posterior-superior pancreaticoduodenal nodes. From these lower portal areas, the lymphatics course to the celiac, superior mesenteric, and interaortocaval nodes. So exposure to this region is a necessary step in the operative staging of gallbladder cancer. An important finding was that some of the lymphatics appear to drain directly from the pericholedochal nodes to the interaortocaval nodes found in the retropancreatic space. These connections may offer an explanation for the often advanced nature of the gallbladder cancer at diagnosis and highlight the importance of analyzing the retropancreatic area radiologically and with full Cocker maneuver at surgery to stage patients with gallbladder cancer properly. For the pathogenesis, the precise pathway linking the different genetic mutations that are responsible for gallbladder cancer is not clear. Several pathways in the pathogenesis of gallbladder cancer have been described. This is the gallbladder carcinogenesis and dissemination model. This skeletal framework, the skeletal framework of this model is based on evidence indicating that primal to development of gallbladder cancer is the existence of chronic inflammation. Chronic inflammation results either due to gallstones or due to changes in the bile owing to the reflux of pancreatic juice into the CBD induced by the EPBDJ. Chronic inflammation secondary to gallstone is more likely to lead to metaplasia rather than hyperplasia, while cholecystitis due to bile leak is more likely lead to hyperplasia, and then it will lead to dysplasia. Dysplasia is a pre-malignant lesion that potentially develops into in situ carcinoma, and then invasive adenocarcinoma, and eventually metastases to lymph nodes, liver, and other organs. Each step has been associated with a series of molecular aberrations. For instance, the earliest events observed in gallbladder cancer pathogenesis is the loss of your p53. This is followed by the loss of heterozygosity at locations 3P and 8P, and then followed by mutations in other tumor suppressors and cell cycle regulators. This is an inflammatory cascade hypothesis in relation to the development of gallbladder cancer. This is as yet a hypothetical model for gallbladder carcinogenesis via inflammatory markers derived from observations in studies examining the expression of these markers in various stages of gallbladder carcinogenesis. Example is the COX-2 overexpression. It occurs early in the pathogenetic cascade of gallbladder cancer. And it is detected in high proportion in dysplasia and invasive adenocarcinoma as compared with the normal epithelium. This model helped us decipher a possible cause for the inflammatory stimulus that plays a significant role in the development of gallbladder cancer. Now we go to the clinical presentation. There are three common clinical scenarios for gallbladder cancer. First, it could be identified by final pathology after routine cholecystectomy. It could be discovered intraoperatively or suspected before surgery. Gallbladder cancer is notorious for being asymptomatic in its early stage. When there is an associated symptom, however, gallbladder cancer tends to present in a similar manner to biliary colic or chronic cholecystitis. This table summarizes the signs and symptoms at presentation from large reviews. Throughout the years, the presentation was remarkably similar in that most patients present with abdominal pain, jaundice, weight loss, and also anemia. Over time, however, a decrease was seen in the percentage of patients who presented with weight loss, while the percentage of patients presenting with abdominal pain and jaundice was similar. Four factors have been strongly associated with findings of cancer at cholecystectomy. That is age, 65 years or older, female gender, Asian or African American race, with elevated alkaline phosphatase. In general, the diagnosis of gallbladder cancer should be considered in an elderly patient with constant right upper quadrant pain, with weight loss and anorexia or both. Weight loss, anorexia, jaundice are signs of advanced disease. The presence of jaundice is a troubling sign because it suggests porta-hepatis involvement with tumor. The presence of palpable mass is clearly an ominous finding and predicts a higher rate of irresectability and advanced disease. Now we go to the final part of my lecture, which is the staging. Over the years, a variety of staging systems for gallbladder cancer have been proposed based on prognostic, clinical, and pathologic factors. Historically, the AGCC, the Japanese biliary surgical system, and the modified Niven system were all used, but we are most commonly using the AGCC system. The AGCC system was issued in 2010 with stage groupings that were changed to correlate with resectability and patient outcome. It utilizes tumor depth, nodal status, and presence of metastasis to place patients into 4 stages based on pathologic and radiographic findings. T1 tumors are divided into 2 groups. The T1A tumors invade the lamina propria of the gallbladder. T1B tumors invade the muscular layers. T2 tumors spread beyond the connective tissue layers. Anatomically, this translates to the spread into the gallbladder serosa of cystic plate but not the liver parenchyma. T3 spreads through the gallbladder serosa and invade the liver, extrahepatic bile ducts or perihepatic organs. T4 lesions invade multiple extrahepatic organs and or major vessels and generally reflect locally unresectable disease. This 7th edition staging reclassified locally unresectable T4 tumors as stage 4 already. The end stage comprises NO, no nodal metastasis, N1, positive regional nodal disease, and N2, distant pericaval, periaortic, superior mesenteric, or celiac artery node. In this 7th edition, N1 nodes are lymph nodes adjacent to the cystic duct, hepatic artery, and portal vein. If there is a disease outside this area, this is already considered as M1 disease. The T, N, and M scores are then arranged into stages. Stage 1 includes node negative T1, and stage 2 is node negative T2. Stage 3 includes T3 negative node and T1 to 3 node positive N1 disease. Stage 4 consists of any T or N score with metastatic disease, with N2 disease now classified as metastatic disease. So that's the end of my lecture. Thank you for listening.
Thank you very much, Dr. Guru. So as I mentioned a while ago, we will have the Q&A after all the lectures. So we go to our next lecture. Our next speaker is a graduate of University of Santo Tomas, Faculty of Medicine and Surgery. He had his residency training in anatomic and clinical pathology in National Kidney and Transplant Institute. He took his fellowship trainings on gastrointestinal and liver pathology at Singapore General Hospital and Beth Israel Medical Center, Albert Einstein College of Medicine in New York. He is the head and chairman of laboratory at Cardinal Santos Medical Center and Sacred Heart Hospital of Malolos. He is also a training officer at Makati Medical Center and National Kidney and Transplant Institute. A batchmate of mine in medicine class, ladies and gentlemen, Dr. Paulo Giovanni Mendoza.
Good evening, everybody. Thanks, John. Thank you for the organizers for the invite to share with you histopathology about gallbladder cancer. As discussed by the first speaker, Dr. Guru, gallbladder cancer is the most common cancer of the biliary tract. And it's usually, in 90% of the time, it is associated with cholelithiasis. Usually, it is advanced when discovered, and it is more common in female than in males, and usually seen among patients who are elderly or more than 60 years old. Common location of these tumors are about 60% in the fundus, 30% in the body, and 10% in the neck. So as this tumor is usually an incidental finding, most of the time it is usually discovered during pathologic evaluation. This is seen about upon opening of the specimen when it is submitted in the laboratory. So As this is most of the time an incidental finding, it is important that the specimen is received in the laboratory intact, meaning it is not macerated, it is not squeezed, and it is placed in a proper container. Because as we discussed, it is important that we evaluate the entire layer of the gallbladder because it is the most important factor in telling you the extent or the depth of invasion. Because once the gallbladder is squeezed or forcefully squeezed into a narrow-mouthed specimen container, then there is a likelihood that the tumor inside would be dislodged or would be disfigured, and it would be hard for us to examine it completely microscopically. So that's one. It is important for us to receive the specimen intact. Also, with the 8th edition of AJCC, it is important with gallbladder cancer that there is a surface orientation because T2 is separated into T2A and T2B depending on the orientation of the surface. So coordination with the surgeon is important in dealing with gallbladder carcinoma because while the specimen is at the OR before sending it to the laboratory, you may tag it with suture representing the surface facing the liver and representing this another suture representing the surface facing the peritoneum. Of course, as you send the specimen to the laboratory, pertinent information for us to diagnose it fully is also important. As we examine the specimen, when we notice dysplastic changes, then it is a trigger for us to submit multiple sections or submit entirely the specimen to rule out presence of invasion. Because in routine gallbladder specimen, we would just usually submit 3 to 4 sections coming from the neck, the body, and the fundus. So in the event that there is no obvious tumor, presence of dysplasia is a trigger factor for us to add some more section or entirely submit the specimen for further microscopic evaluation. Usually, biopsy is not advisable in view of biliary peritonitis in 5% of the time. However, fine needle aspiration cytology is being practiced in some areas wherein gallbladder cancer is more common. The process or the carcinogenesis of gallbladder is a continuum. It is a mainly an inflammatory process being the main event in the carcinogenesis of gallbladder. So due to repeated chronic inflammation, there is death of the epithelial lining of the gallbladder. So as it replaced the lining, it will subsequently give you a metaplasia wherein a differentiated cell that is not ordinarily found inside the organ is replacing the natural lining of the gallbladder. So in this third picture, you can see with the red arrow the goblet cells showing you the metaplasia. And then due to this repeated process of inflammation, we can develop dysplasia. And from this dysplasia, it can progress to invasive carcinoma, wherein you can see that the nuclei become hyperchromatic and the nucleoli become became multiple and more prominent in this diagram. In an actual microscopic picture, this first yellow arrow is pointing towards the normal gallbladder epithelium. Then you can appreciate the pseudostratification of the hyperchromatic nuclei, telling us that there is dysplasia. Next picture, you can appreciate that the nuclei have become dishesive, or there is a loss of polarity, telling us that there is a carcinoma. And further down, there is already an invasion, or what we call the adenocarcinoma. As we go with this next slide, the histology of the gallbladder cancer would usually give us an adenocarcinoma as the most common type of histology of our gallbladder carcinoma. Usually, the gross features of this gallbladder tumor are flat with thickened wall. Some are friable and fungating, and most of the time, they are expansive. So under the heading of adenocarcinoma, we can subtype it into biliary type adenocarcinoma, intestinal type adenocarcinoma, and mucinous carcinoma. Other non-common histologic types are poorly cohesive carcinoma, squamous cell carcinoma, undifferentiated carcinoma, adenosquamous carcinoma, neuroendocrine tumor, and mixed tumor types. For histologic grading of adenocarcinoma, it is usually based on the WHO grading system, and this is based on the extent of glandular differentiation. We call it well differentiated when there is a greater than 95% of the tumor is composed of glands, moderately differentiated when 50 to 95% of the tumor is composed of glands, and poorly differentiated when 49% or less of the tumor is composed of glands. The four pictures on the right lower side of the slide represents the different grades of this adenocarcinoma, wherein the most number of glands represent the well-differentiated adenocarcinoma. For WHO, there is also a grade 4 histologic grade, and this represents the tumor with no squamous or no glandular component. But with AJCC, AJCC grade 4 for gallbladder carcinoma is not included. But just to tell you that when you receive a report that it is stating grade 4 gallbladder carcinoma, then it means that the tumor is a carcinoma but with no definite squamous or no definite glandular differentiation. Also, on this grading is poorly cohesive carcinoma. With poorly cohesive carcinoma, it is automatically graded as grade 3. Poorly cohesive carcinoma are composed of individual cells. Some are showing signet ring cell pattern. Although tumor stage is probably the most important prognostic factor for patient outcome, histologic grade, especially poor differentiation, also has an impact on survival with regard to gallbladder carcinoma. Other tumor types, though rare, are neuroendocrine tumor, squamous cell carcinoma, poorly cohesive carcinoma or signet ring cell carcinoma, and mucinous carcinoma. This squamous cell carcinoma, poorly cohesive carcinoma, and mucinous carcinoma are said to be more aggressive compared to the ordinary biliary type or intestinal type adenocarcinoma. For the squamous cell carcinoma, just like in other organs, behavior is more advanced during presentation, and the prognosis is worse compared with the ordinary adenocarcinoma. So for pathologic staging, the best estimation of prognosis for gallbladder carcinoma is related to the anatomic extent of the lesion. For this slide, we can see in this diagram the different layers of the gallbladder wall. The outer lining, the connective tissue or the perimuscular tissue, the muscle or the muscularis mucosa. This is a thin muscular lining before the lamina propria or the connective tissue, or the connective tissue contains the uh, loose portion of the gallbladder wall, and then the inner lining or the mucosa. From this lining, we would tell you the extent of infiltration of the tumor, and this extent of infiltration would tell us the pathologic stage and would further help us in the management of the patient. Thus, it is important that we receive the gallbladder specimen in the laboratory intact, not forcefully squeezed inside the container, because once the specimen starts to be preserved by formalin, it becomes firm and hard for us to take it out, and we would need to break the bottle, and it might cause for the specimen to be disfigured, making it difficult for us to read it microscopically because the layers have been disrupted. So for pathologic staging, the AJCC 8th edition would divide the T2 into T2A and T2B. TIS represents the tumor being confined within the glandular basement membrane. This is usually referred also as high-grade dysplasia or carcinoma in situ. Thus, if we encounter this kind of lesion wherein the dysplasia is just confined in the lining, it is a trigger for us to submit more sections or submit entirely the specimen for us to rule out presence of deeper invasion. So T1, as mentioned a while ago, is invasion into the lamina propria, and it is segregated into T1A and T1B. For T1A, it's invasion up to the lamina propria, and T1B up to the muscularis mucosa or the muscular layer. For T2, it is the perimuscular tissue, and this is the delineation for the worse, a behavior that is more aggressive. So for T2A and T2B, we can see from this diagram that T2B is the one facing the liver, and T2A is the one facing the peritoneal surface. Thus, it is important for us to be oriented, and maybe you can put some ink or some suture for the surface facing the liver and for the surface facing the peritoneum for a more appropriate evaluation and also for better pathologic staging. So other factors that being reported with gallbladder CA are presence of negative margins, because complete surgical resection with negative margins remains the most effective therapy for gallbladder, with the 5-year survival advantages of 30% for patients with negative margins compared with those with microscopic or macroscopic residual disease. And also another factor that we are also reporting are presence of blood vessel or lymphatic invasion, and because this also implies an adverse prognostic feature in some but not in all studies. Presence of perineural invasion is also a very common finding in gallbladder carcinoma and has been identified as giving an adverse prognostic factor in some but not all studies. Perineural invasion has been associated with spread of carcinoma beyond the gallbladder to involve the biliary tree. I think that's the end of my lecture. Thank you very much.
Thank you very much, Dr. Mendoza. So we proceed to our third lecture. Our third speaker is another product of UST, Faculty of Medicine and Surgery. She finished her diagnostic radiology residency and CT MRI fellowship trainings at Makati Medical Center. She also had fellowship training on body and cardiothoracic imaging at Keck School of Medicine, University of Southern California in Los Angeles, USA. She is currently the training officer for radiology residency training program at Makati Medical Center and a radiology consultant at Chinese General Hospital. If Dr. Mendoza was my batchmate, this time she was my senior intern when I was a medical clerk. Ladies and gentlemen, Dr. Richie Pilapil.
So good evening. Thank you to the organizers for inviting me to be part of this webinar. So for tonight, I will be showing to you the imaging findings of gallbladder cancer, some imaging pitfalls, and imaging appearance of some common benign differential diagnoses often confused with gallbladder cancer. So the most common imaging finding of gallbladder carcinoma is a large mass obscuring and replacing the gallbladder, followed by focal or diffuse gallbladder wall thickening and polypoid intraluminal mass. So in the mass forming pattern, the gallbladder is replaced partially or completely by a mass, and differentiation between gallbladder carcinoma and other malignancies can be confusing, especially if there is invasion of the liver and other adjacent structures. So like in this case of gallbladder cancer, we see a large irregular mass involving the gallbladder, which is enclosing and invading the duodenum and also extending towards the hepatic hilum, causing intrahepatic biliary ductal dilatation. So cases like this can often be confused with cholangiocarcinoma. This is another case wherein this was initially read out as intrahepatic cholangiocarcinoma because on CT scan, they see this large heterogeneous mass involving hepatic segment 5, and they were not able to identify the gallbladder. However, on T2-weighted MRI, we can identify the gallbladder here, and there is diffuse thickening of the gallbladder with invasion of the liver parenchyma, seen here as a heterogeneous mixed intensity mass. So this is another case wherein there is a large mass encasing the common bile duct and involving the pancreatic head. This was initially signed out as a pancreatic neoplasm. However, histopathology revealed adenocarcinoma of the gallbladder. It actually came from this mass in the gallbladder neck, which was not recognized on the CT scan. So another case of gallbladder cancer, which may be misdiagnosed as cholangiocarcinoma. So this is an MRCP image which shows narrowing of the mid-extrahepatic duct with dilatation of the upstream bile ducts. Enhanced contrast CT scan shows an enhancing soft tissue mass enveloping the extrahepatic duct and causing the stricture. The soft tissue mass also extends towards the cystic duct and the gallbladder neck. So this was actually a gallbladder neck cancer spreading to the cystic duct and extrahepatic duct. So for any mass involving hepatic segment 5 and adjacent organs, and for any stricture in the extrahepatic duct, always inspect the gallbladder wall and cystic duct for any abnormal thickening or mass that can help differentiate gallbladder carcinoma from other malignancies. So the next imaging appearance of gallbladder carcinoma is focal or diffuse gallbladder wall thickening. So in ultrasound, they may be seen as irregular echogenic gallbladder wall thickening, or they may also appear as a sessile echogenic mass with adjacent focal wall thickening, or as a non-mobile mass completely filling the gallbladder lumen. So this is a case of a woman with segmental wall thickening in the fundus. This was initially diagnosed as adenomyomatosis. However, imaging at 1.5 and 4 years revealed progression of the mass. At 1.5 years, the possibility of malignancy was already raised. However, patient refused any intervention. So this slow-growing mass turned out to be a well-differentiated adenosquamous carcinoma. So in cases like this with segmental wall thickening, it is not easy to differentiate this early stage cancer from adenomyomatosis, and further examination with ultrasound or MRI may be helpful. So here we see segmental wall thickening in the fundus. Ultrasound was done, which revealed V-shaped reverberation artifact resembling a comet tail. This is actually the comet tail sign of adenomyomatosis on ultrasound. So on MRI, this is seen as numerous small T2 hyperintense foci, which looks like a string of pearl. So this string of pearl sign is a specific sign of adenomyomatosis on MRI that can differentiate it from malignancy. Here is another case of focal wall thickening in the gallbladder fundus. T2-weighted MRI showed focal wall thickening with some heterogeneous signal. This was also initially suspected to be adenomyomatosis. However, follow-up CT scan showed progression of the mass. So if we look back here on the T2-weighted MRI, we can see that it's soft tissue thickening that is the predominant feature, and there is very little or no cystic components, which is this is not very typical for adenomyomatosis as I've shown you. So remember that symmetric wall thickening, intramural cystic spaces, or echogenic foci, reverberation artifacts on ultrasound, and string of pearl sign on MRI are features of adenomyomatosis. However, irregular outer wall thickening, irregularity, focal discontinuity, or thickening of the innermost layer, and intralesional vascularity on ultrasound are significantly associated with cancer. So Dr. Kim and company analyzed the enhancement pattern of gallbladder wall thickening to differentiate gallbladder cancer from cholecystitis. In their study, they found out that enhancing inner wall that is more than 2.6 millimeter thick, hyper-enhancing inner wall, thin outer wall measuring less than 3.4 millimeters, weakly enhancing or non-enhancing outer wall, irregular wall thickening, and focal wall thickening are all highly associated with gallbladder cancer. So they describe different enhancement patterns. So this one, they describe this as a heterogeneously enhancing thick one-layer pattern, which we see here in a case of gallbladder carcinoma, which had a segmental heterogeneously enhancing thick one-layer. So another case of a heterogeneously enhancing thick one-layer pattern with irregular cystic spaces and irregularity of the inner wall in a case of gallbladder cancer. So this is actually a false positive case of gallbladder cancer. Here, we see segmental heterogeneous heterogeneously enhancing thick one-layer pattern. However, on other areas of the gallbladder, we only see a weakly enhancing thin inner wall and a non-enhancing thick outer wall. This is a case of chronic cholecystitis with phlegmon. So this was actually the phlegmon. So the one of the differential diagnoses for this type of enhancement is xanthogranulomatous cholecystitis. So here, this is the imaging finding of xanthogranulomatous cholecystitis. We see diffuse gallbladder wall thickening with multiple intramural hypodense lesions and an intact mucosal line. So on T2 weighted image, we also see diffuse gallbladder wall thickening, intramural T2 hyperintense lesions, and an intact mucosal line. MRI is useful in this case because the lipid-laden macrophages within the wall causes decrease in the signal on the out-of-phase image compared to the in-phase. So this is a case of a woman with xanthogranulomatous cholecystitis coexisting with gallbladder cancer. So here we see diffuse gallbladder wall thickening and intramural hypodense lesions, which are features seen in xanthogranulomatous cholecystitis. However, in the neck, we see this small, more solidly hyper-enhancing lesion, which represented the gallbladder cancer in this case. So another pattern that they describe is a thick, hyper-enhancing inner wall and a thin, weakly or non-enhancing outer wall. So here in this case of gallbladder cancer, we see this thick inner wall, which is hyper-enhancing compared to the liver parenchyma on portal venous face, and a thin, weakly enhancing outer wall. So this is another case of gallbladder cancer showing a thick, hyper-enhancing inner wall and a weakly enhancing outer wall. So the first two patterns that I presented are most often associated with malignancy. So other imaging findings that they describe, this one is a thin, weakly enhancing inner layer and a non-enhancing thin outer layer, seen here in a case of chronic calculous cholecystitis. So here we see the gallstones, the lumen is collapsed, and then the thin inner layer, which is hypo-enhancing or weakly enhancing with fuzzy margins and a non-enhancing outer layer. And the last pattern that they describe is that of acute cholecystitis. So they describe this as a weakly enhancing thin inner layer and an thick outer layer, which is non-enhancing, suggesting subserosal edema and pericholecystic fluid. So this is a case which presented as a case of acute cholecystitis. So here we see a thin, weakly enhancing inner layer and a non-enhancing outer layer with adjacent reactive edema in the gallbladder, in the liver. However, there is a small enhancing nodule in the gallbladder neck, which caused the cholecystitis. So because acute cholecystitis can develop as a result of an obstructing cancer in the gallbladder neck, careful examination of the gallbladder outlet for any focally enhancing lesion or mass is mandatory. And the last imaging pattern of gallbladder cancer is a polypoid intraluminal mass. So here is a case of a gallbladder cancer on ultrasound showing as a well-defined echogenic mass with ill-defined posterior acoustic shadowing. On CT scan, we see it as a soft tissue mass with intratumoral calcifications. Another case of gallbladder cancer presenting as a 3 centimeter wide sessile polypoid mass with adjacent focal wall thickening. So at CT scan, we saw it as an enhancing front-like lesion which exhibits marked FDG uptake on PET-CT scan. So on MRI, any polypoid lesion may not be visible on non-contrast T1 weighted image because they may be isointense or hypointense to the bile. But on contrast, they would uptake the contrast, and DWI they would show as hyperintense with signal dropout on ADC. So this is actually compatible with malignancy, which was proven in surgery. Another case of a malignant polyp showing a well-defined echogenic polypoid lesion with hypoechoic portions within. So on CT scan, it is seen as an enhancing sessile mass with basal invagination. So this is actually a case of papillary adenocarcinoma with invasion up to the subserosal layer. So common differential diagnosis of polypoid lesions are sludge ball and cholesterol polyps. So this ultrasound showed a polypoid lesion near the gallbladder neck, which moved in location. This is very classic for a sludge ball. On CT scan, we usually cannot see the sludge ball. Cholesterol polyps, on the other hand, appear as small echogenic intraluminal lesions attached to the gallbladder wall. On T2-weighted MRI, they appear as small filling defects which are attached to the gallbladder wall. These cholesterol polyps also enhance like neoplastic polyps, but on CT scan, we usually do not see these cholesterol polyps on an enhanced CT scan. So in summary, always remember that gallbladder cancer may mimic the imaging appearance of benign disease, and it may coexist with benign disease that can obscure the malignancy. So in cases of large confluent mass, assessment of the gallbladder wall and cystic duct for any abnormal thickening or mass can help differentiate gallbladder cancer from other malignancies. And for those presenting as gallbladder wall thickening, hyper-enhancing thick inner wall, weakly or non-enhancing thin outer wall, irregular wall thickening, and focal involvement are highly associated with malignancy. Whereas sessile-shaped polyps with internal hypoechoic foci with accompanying focal wall thickening, basal indentation, and measuring more than 1 centimeter have higher likelihood of malignancy. Thank you.
Thank you very much, Dr. Pilapil, for that very thorough lecture on the imaging. Going to our next lecture. Our next speaker is not new to us, a surgeon par excellence. He is one of the pillars and pioneers of the Philippine Association of Hepatopancreatobiliary Surgeons. Presently, he is the Dean of Ateneo School of Medicine and Public Health. He is the Chief of Section of Hepatobiliary and Pancreatic Surgery at the Medical City, and also the head of the Pancreas Cancer Unit of the same institution. Ladies and gentlemen, it is my honor to introduce to you one of my surgical professors before at UST, Dr. Zenon Alfonso.
Thank you, John. Can you see my slides now? All right, for those of you who are visual, can take a look at my slides. For those of you who are textual, can follow my notes. My notes, I use them to keep me within 20 minutes. Otherwise, I'll run over the time of Professor Anil and Dr. Bello, and they'll shut me down. Good evening, ladies and gentlemen. I would like to thank the Committee on Surgical Education and the board of the Philippine Association of Hepatopancreatobiliary Surgeons for making me a part of this webinar panel discussion on gallbladder cancer. Gallbladder cancer, as you have heard, is relatively rare in the Philippines, but not in India, not in Chile. Its clinical presentation is not specific and it's easily confused with inflammatory conditions, as you have seen, and of the gallbladder and cholelithiasis. CEA in 19-9 or carbonic anhydrase 19-9 are generally not useful. How do I make this? Right, our objective in the next 20 minutes is to enable each of you to make a practical, competent, and rational decision in managing cases of gallbladder cancer. Of what appears to be malignancy of the gallbladder. In this course, we will share with you our experience in 3 cases during the last 6 months before the COVID lockdown. Now, let me explain why practical, competent, and rational decision. First, practical, because you need to consider the context of your patient, who are in all likelihood elderly, above 60 years old, asymptomatic in most of the times, particularly those who have been diagnosed preoperatively, or with minimal symptoms except those in late stages of the disease. And in 70% of cases have recently undergone cholecystectomy, a great majority. His or her biomedical makeup, principally comorbidities, functional capacity, his or her psycho-emotional status, to desire to take a chance for cure against an extensive, probably extensive surgery or prolongation of life, depending on the stage of the disease, his and her social, cultural, and even economic capacity. And in many cases, who is the decision maker or financer, particularly when you're dealing with anything worse than stage 1 or T1A. This is so because only stage T1A is treatable with simple cholecystectomy, usually done by most of us general surgeons. The studies of Shirai et al. Or Yamaguchi and Tsuneyoshi et al. As early as 1992 to year 2000 corroborated with T1A tumors with negative margin standard cholecystectomy with intact gallbladder cures 85 to 100% of cases. No additional resection is indicated. There isn't much issue on practical decision making for T1A tumors. However, anything beyond T1A tumors, you will have to consider a lot of things about your patient. T1B tumors, invasion into the muscularis layer is controversial up to this time. However, most recent studies, and I'm sure Professor Anil will show this, showed residual malignancy after simple cholecystectomy, hence necessitating reoperation for T1B and worse, and definitive resection. But the benefits are varied. Hari et al. 2013, Kang et al. In 2007 showed a wide range of 5-year survival of T1B GB cancers between 30%, a low of 30%, and a high of 75% survival even without reoperation. Your practical decision rests on patients' biomedical, psycho-emotional, and even socioeconomic disposition. T2 tumors are not controversial. Reoperation is clearly indicated. There are many points, however, for you on practical decision making. My second point is competent decision, because to adequately manage gallbladder cancers, you need, in my opinion, to have at least 3 institutional and individual competencies. Number one, competence in imaging. You have heard our previous lecturer. Very critical, specifically hepatobiliary ultrasound, HPV CT scan, and MRI. Not to mention PET-CT, competent cytopathology. The second, you have heard the previous speaker, frozen section is a critical tool and must be able to clearly distinguish biliary dysplasia from neoplasia and carcinoma. They are your best friends if you want to venture into gallbladder cancer surgery. A cytopathologist would be your best friend. And of course, surgical capacity and comfort in performing procedures more complex than cholecystectomy, such as but not limited to cystic duct frozen section, extrahepatic bile duct resection, radical cholecystectomy or extended cholecystectomy, liver segmentectomy or limited liver segmentectomy, hepatoduodenal lymphadenectomy, extended right hepatectomy, and in rare cases, even hepatopancreaticoduodenectomy. Let's go over each one of these competencies, if you don't mind, because this is the meat of my presentation. So remember, imaging, cytopathology, and your surgical comfort or capacity. Competent imaging. Let's start with ultrasonography. It's an excellent imaging for the gallbladder. We have seen that in about 30% of cases. It is capable of preoperatively diagnosing even early GB cancers. But what do you look for? Discontinuous mucosa, echogenic mucosa. Look at this mucosa and look at that part, and submucosal echogenicity, submucosal echolucency. Let me see if we can see that here. Sharing with you one of our 3 cases in the last 6 months pre-COVID. The 69-year-old female who refused to undergo surgical resection, virtually asymptomatic, enjoyed her 3-year ultrasonographic follow-up from an adenomatous gallbladder polyp turned into her most precious carcinoma, which should have been removed 2 years back. In her case, competent imaging consists of a triple contrast with triphasic IV contrast CT scan with multiplanar 3-dimensional recon and sub-millimeter collimator cuts, very, very important, from the liver down to the periampullary area. This is her abdominal triphasic IV contrast CT scan showing a non-thickened gallbladder wall with an irregularly shaped nodular enhancing mass occupying the gallbladder lumen. From the body to the neck, there seems to be no evidence of hepatic extension in this case, and no evidence of adjacent organ involvement. Although we are suspicious about this node, the node of Lund, usually mistaken or called the node of Calot. There's no such thing. It's the node of Lund. Every time you examine a CT, and this is required of all HPV surgeons and HPV fellows in training, we are required to examine all the 3 planes: the coronal view to search for liver metastasis, adjacent organ involvement, and peritoneal metastasis. That's why the collimator cuts has to be sub-millimeter, if possible, 0.7 or 0.6 millimeters in thin slices, so that you'll be able to catch smaller than 1 millimeter peritoneal metastasis, for which gallbladder cancers are notorious about. Axial and sagittal planes to determine vascular and ductal involvement. Very critical for you as surgeons to examine both the eggshell in many slices, thin slices, and sagittal planes. You need to focus on the vascular structures, their involvement, whether there is abutment, where there is involvement of the wall of the vessels, or even intraluminal thrombosis, malignant thrombosis, including enlarged lymph nodes. In this case, we can see clearly the blood vessels and the regional lymph basins pertinent to the gallbladder. And I'd like to call your attention, no, to the nodes. The node of Lund I have shown you earlier, all right, which is within the triangle of Collot, seems to be suspiciously enlarged, but the nodes along the anterior and posterior aspects of the hepatoduodenal ligament, no, very critical for you to look at. I cannot show you the entire series of plates because it will take time. But let me call your attention here. We look at this area, the interaortocaval area. If this is filled with nodes, this is M1, and therefore the likelihood you will not resect, will not go for an extensive operation, or you may send your patients to Dr. Bello or your favorite medical oncologist first. No? The interaortocaval nodes are very critical for you to look at. This is the aorta, inferior vena cava, aorta, inferior vena cava. Look at this area. If there are enlarged nodes, this is the SMV, this is the SMA. Look at those areas and try to identify if there are enlarged nodes. Any enlarged nodes will already tell you what's the extent of the N, or if there's any N. We just can't underestimate the competence in clinical assessment using preoperative images. Spend some time with your radiologist and discuss the images to the minutest of details. This is what we teach all our residents and fellows who would want to learn, who would want to manage gallbladder cancer in the future. No? So much with imaging competence. Let's go to the second competence. Your best friend, your cytopathologist. The second important, take a look at your institution before you embark in managing your next case of gallbladder cancer. Do you have one? Is there an equipped and reliable cytopathology section? Preferably an HPB cytopathologist if you have one. No? Many HPB surgeons say if you don't have one, don't attempt to operate on a GB cancer case. Maybe you should move over or refer your patient to a center. HPB pathology is one, if not one of the more difficult subspecialty, if you want to call it, in the practice of anatomic pathology. And we have been burned many times, with all due respect to our friends, no, in the past, making critical decisions whether we will do extensive resections or not based on some unreliable frozen section readings. You know, very, very important for us that you need to communicate quite clearly. Do not destroy the specimen. Send them the bigger specimen or the biggest specimen that you can send. And please be careful in sending them the specimen because they want those specimen intact for their own assessment. Frozen section is one of the most critical bases of the decision-making process among those diagnosed preoperatively, intraoperatively, and even post-cholecystectomized cases. And let me go through this briefly. Preoperatively diagnosed, a definitive extended cholecystectomy is planned. The surgeon must always include in the surgical procedure a frozen section of what? The cystic duct stump. Regardless of the location of the tumor, because GB cancers tend to be invasively diffuse, surreptitiously. You need this information to decide whether you will perform extrahepatic ductal resection or not. That's why it's very critical to send the frozen section from the cut surface or cut end of your cystic duct. If it's positive, you go for resection of the bile duct. If it's negative, then you stop there. Assuming the diagnosis of gallbladder cancer now is intraoperatively, suddenly you're faced with a case where you can palpate a mass
It turned out to be a mass, not a cholelithiasis. And the tumor size and depth is suspiciously big and deep. Frozen section of the node of lung within the triangle of Calot, of any enlarged node in the gallbladder regional basin may be done as basis for the regional lymphadenectomy. Some Japanese would even venture into first doing a lymph node sampling or lymph node frozen section from the interaortocaval basin. And if it's positive, that's labeled M1, and therefore any extensive resection is ruled out. Finally, in the cases of reoperative surgery for a missed gallbladder cancer, besides a careful review of the original, you have to review the original histopathologic report, because the outcome, the overall outcome of whatever you're going to do depends on the T stage of the first operation, not on your extent of operation. It is the T stage. That's why you need to review. If it's not indicated there clearly in the first histopath report, you need to subject those slides under another one of your experts, cytopathologists. You know? Frozen section of the interaortic caval lymph nodes, when positive, can prevent a useless extensive surgery such as a pancreaticoduodenectomy. A positive node in this is equivalent to M1. Any extensive surgery may be difficult to justify if it were positive. I cannot again overemphasize the role of a reliable cytopathologist. These are most important. The third competency that we ought to assess ourselves before embarking on managing GP cancers is our own capacity, you and your team. What is your level of comfort in both the decision-making process and the technical surgical skills to perform the definitive surgical procedure appropriate to the disease or to the stage of the disease, given the limitations of your surgical team and of the equipment available in your institution? Let's dissect this important competence further. This surgical competence requires 5 components, in my opinion. The first component is knowledge of the tumor staging, and that was given to us by Dr. Anissa. Whether you're using, whichever you're using, whether it's the modified Navin or the Japanese or the American Joint Cancer Committee, personally, I always use the AJCC 7th edition. Second component is the knowledge and skills in liver resection. Of course, based to this is the knowledge of the liver anatomy and also physiology. Do you have it? These are the bottom line questions we're going to ask ourselves. Number 3, knowledge and skills in extrahepatic bile duct resection. Are you comfortable in doing resection of the bile duct from the porta down to the level of the superior border of the pancreas? 4th, knowledge and surgical skills in regional lymphadenectomy. And this was shown to us by also Dr. Anissa. Where are the lymph nodes? Coming from the porta, anterior to the hepatoduodenal ligament, the retroduodenal basin, where are the nodes posterior to the hepatoduodenal ligaments? They're about 10 or 12. Knowledge and skills, finally, in pancreaticoduodenectomy, if there is a need to do a resection of the head of the pancreas, where about 3 or 4 lymph nodes are draining as part of the regional basin of the gallbladder cancer. These five are very important for us. These questions will have to be answered by yourselves. Why? Because the knowledge of tumor staging, whether it's modified Nevin or Japanese or the AJCC 7th edition, and the stage of the tumor you're dealing with, based on radiologic and pathologic examinations, results are available. And I must tell you that there is a range of difference among all of the reports that you can see, no? You can see so many literatures telling you there's a range of difference in their series, no? That hardly could we make a series. Probably in India they could make randomized clinical trial because they have over 20 per 100,000 cases, no? And also in Chile. But in the Philippines, we cannot make randomized clinical trials and tell you this is the best for T1B, this is the best procedure for T2, and so on and so forth. So we include them in the bracket. No, I'll tell you later why. In the management, this is the reason. The surgical competence is very important. Why? Because the moment the lesion goes beyond T1A, meaning T1B, T2, T2A, T2B, T3, and so on, all of these procedures can happen right in front of your face. And you and your team should be able to make a rational, a practical, competent, and rational decision on what to do. Knowledge and comfort in performing the necessary procedure for the stage of the disease. Again, based on histopath results and radiologic examination that you have done. It must be mentioned here that there is a wide range of differences among the surgeons based on their own retrospective cohorts in terms of routine and non-routine extrahepatic duct resections and regional lymphadenectomy. But mind you, this is the range. One can do an extended cholecystectomy with T1B or a radical cholecystectomy, meaning the entire segments, 4B and 5, or even 2cm, just a 2cm margin of 4 and 5 for T1B, and just biopsy frozen section of the cystic duct. But if the cystic duct frozen section is positive, then you will have to do a extrahepatic bile duct resection. And if you saw a lymph node and you biopsy, when you do, most commonly, most of us surgeons, HPB surgeons, when we do extrahepatic ductal resection, we might as well proceed and do a lymphadenectomy. But the patterns, it seems to me, are the following. For T1B, extended cholecystectomy, which means removal of the gallbladder en bloc with a wedge of 2 centimeters from segments 4B and 5, plus frozen section of the cystic duct. If negative, frozen section, the surgery is complete. If positive, resection of the extrahepatic bile duct down to the superior border of the pancreas with or without regional lymphadenectomy. For T2 tumors, most surgeons would do routine extended cholecystectomy with bile duct resection and lymphadenectomy, even without the benefit of frozen section. For T3 tumors, most surgeons will routinely do en bloc 4B and 5 segmentectomies or extended right hepatectomy, depending on the findings of intraoperative ultrasound, with bile duct resection and regional lymphadenectomy and en bloc resection of adjacent organs that are involved with the tumor. We follow this because our team, we usually have the use or the easy use or access to intraop ultrasound. For T3 tumors, some surgeons routinely biopsy first the celiac and interaortocaval nodes before proceeding with the extensive surgery. Some Japanese HPB surgeons, after a negative celiac and interaortocaval node biopsy, will do no hepatopancreaticoduodenectomy further. Due to its relative rarity in our country, there are no randomized clinical trials. I think I've mentioned this already, that can prove benefit or disadvantage or advantages of one over the other. Perhaps the speaker after me will be able to tell us more about this, no? And we'll have more scientific basis and proofs showing the benefits of one over the other. In short, the competencies of the surgeon further requires knowledge and skills in liver resection, knowledge and skills in bile duct resection and anastomosis, knowledge of the regional basin of the gallbladder, regional lymph node basins of the gallbladder, namely the porta hepatis group, the gastrohepatic ligament group, located anterior and posterior to the hepatoduodenal ligament, and the retroduodenal group of nodes. Just about 10 or 12, a dozen nodes within the highlighted green area here. All right. Some of the nodes are on the posterior portion of the head of the pancreas. So there is a requirement that you need to flip after doing a full cocker or mobilization of the duodenum. You need to flip it over the left side and then look at the nodes. And in some cases, we needed to do a pancreatic duodenectomy along with the resections in the upper portion. And of course, if you are a follower with Japanese, you need to be able to do as an extensive surgery as liver resection along with Whipple procedure. And I'm going towards the end. Finally, while it is beyond the scope of my presentation, I think it's very, very important. This is something very important. Dr. Hanisa presented the classic anatomy of the biliary tree, gallbladder, and its surrounding organs. But you will find yourself surprised if you're doing more of these operations that in 17, a low of 17 to as high as 40% of cases, there are normal variants in the ductal, arterial, and portal anatomy, which can be misleading in some cases, and in other cases, if you are not careful, can be catastrophic in the end, because devascularization, whether it's the arterial, meaning the bile ducts, or the portal, meaning the parenchyma, can lead to catastrophic complications associated with resections and lymphadenectomy in this area. It is therefore quite important, and it's a handy knowledge, that a low of 17 and high of 45% of cases can have normal variants in one or all of the components, whether it's ductal, arterial, or portal. And you ought not be surprised if they do not follow what you thought was the classic anatomy of what you're dealing with in this area. I'd like to share with you a picture of what we did last, I think this was 3 weeks prior to the lockdown, when we did a T2 lesion, and therefore we did a resection of the entire 4B, and then 5, the entire 5, and a part of 8, in fact, in order to get a negative margin. We did this case about 3 weeks, as I've said. This is a 70-year-old, very active female who's very, whose disposition is she wants to get rid of the tumor. And this is a post-lap converted to open, done elsewhere in one of the provinces outside the Metro Manila. And she came out, this is a T2 GB carcinoma. We resected the stomach because we thought this was involved, attached to the gallbladder wall, but turned out to be just negative. I guess I'm the recap. To arrive at a practical, rational decision in the management of gallbladder, let's begin with the context of the patient. It's very, very important, particularly if you're dealing with T1B tumors. Look at the comorbidities, the psycho-emotional state, and biomedical and even financial disposition, because these are extensive procedures of patients who may not feel anything. They don't have any complaints. It's just that they're looking at their histopath report. Make sure that the 3 competencies required are more or less present or easily accessible. And these are imaging, cytopathology service, and the surgical capacity and comfort. The third one is very important. You need to be comfortable in managing or in doing the management in accord with the stage of the disease. The latter, the surgical capacity, has several components, 5 components: tumor staging, knowledge and mastery of the tumor staging, liver resection skills, knowledge and skills in bile duct resection, and anastomosis, regional lymphadenectomy, and even hepatopancreaticoduodenectomy if necessary. But always bear in mind and keep this at the back of your head every time you operate in this area, that you may be dealing with one or several of those variants, whether it is ductal variation or arterial variation from the normal or standard, or portal variation. Thank you very much.
Thank you very much, Dr. Alfonso, for that thorough discussion on surgical points on management of gallbladder cancer. Moving to our fourth speaker. Our fourth speaker is a professor and chief of GI surgery and liver transplantation at the GB Pant Hospital and Maulana Azad Medical College, Delhi University at New Delhi. He completed his fellowship in HPB and liver transplant surgery from London. He has one of the leading experience in the surgical management of gallbladder cancer. He is particularly interested in HPB surgery and is engaged in the laparoscopic management of digestive diseases, including laparoscopic liver and pancreatic surgery. He is currently a member of the National Work Group of National Organ Transplant Program, engaged in promoting cadaveric transplant program at the national level. Ladies and gentlemen, transmitting direct from New Delhi, India, Dr. Anil Agarwal.
Am I audible?
Go ahead, Dr. Agarwal.
Yes,
We can hear you.
I've shared my screen. Yeah, there it is. Yeah. Good evening.
You can see your slides. Good evening.
Yes. Good evening, and thank you very much for the introduction. And it's a pleasure, Catherine. Thank you very much, and also the Philippines Association of HPB Surgery. It's a pleasure to be talking about a subject which is so close to my heart, and we are trying to push the laparoscopic management of gallbladder cancer management. And Professor Senan has very nicely taken us through the surgical management of gallbladder cancer. And over the next 15 to 20 minutes, my brief is to actually convince you that the same things can be done by laparoscopic, and any fear of spread of disease or early recurrence notwithstanding. And I hope that with the smoke evacuators and such other gadgetry, which I think the Medtronics will be talking about in the end, will help us to continue doing the laparoscopic approach. And we will also look forward to that. So I think with that background, I would take you through, of course, when we talk about the minimal invasive surgery, staging laparoscopy or palliative laparoscopy, there's not much to talk about. But just to say that when you do a staging laparoscopy, some lesions are visible on the liver surface or peritoneum as soon as you put in a scope, while some others, like the intra-aortic will need lymph node, will need more dissection, which can also be done laparoscopic. This was, of course, an open picture, and the loco-regionally advanced disease. So we published this paper in Annals of Surgery, in which we talked about 409 patients of primary gallbladder cancer. And we realized that staging laparoscopy obviously can avoid an non-therapeutic laparotomy in these cases. But this was before we were actually doing too many laparoscopic gallbladder cancer, because now obviously if we are doing a laparoscopic radical resection, staging laparoscopy is a part of it. And I think subsequently we started doing a intra-aortic lymph node biopsy also using the laparoscopic approach. And we also started using staging laparoscopy with 2 ports, because we realized that in the initial part of our study, we missed some lesions which were there in the hidden areas of the liver. So I think the second port actually helps to look at these areas, and also take a biopsy if required from if there is a lesion. So this is a picture just showing that this is the region in which you would like to go in and take out the intra-aortic cable lymph node. And so coming to the actual crux of doing a laparoscopic radical cholecystectomy, which is the definitive management for gallbladder cancer. And in that regard, what has actually prevented from surgeons to take to this has been that there's been reports of tumor implantation after laparoscopic cholecystectomy for unsuspected gallbladder cancer. Yeah, so I think, in fact, as I'll take you through, that this data is based on cholecystectomy data and not for the laparoscopic management of gallbladder cancer. So we'll just see that is it fair to extrapolate that data. Now, these are some of the feasibility studies which were there, and I'll come to this Professor Hahn's group study, which paved the way for us also to start laparoscopic radical cholecystectomy. And I think in this, the concerns, apart from that, can it be done with the same radicality, which a lot of surgeons proved that it can be done. I think what prevented surgeons from doing it was that what is the risk of port site metastasis, and will laparoscopic approach lead to early spread? And of course, that does it compromise on the long-term results? And I think there are several studies in which they talk about that the mechanism of port site metastasis could be, differently, because either could direct contamination or indirect. But I think, several studies have proven that role of pneumoperitoneum in causing peritoneal dissemination is negligible. And so I think just coming to that is it really fair to extrapolate the data from the cholecystectomy data to say that doing a laparoscopic radical cholecystectomy is not as safe? The answer is no. And why? Because when you do a cholecystectomy, when you didn't suspect a gallbladder cancer, you are holding the gallbladder from wherever you want to. You are actually going into the tumor area. Whereas if you look at when you do a laparoscopic radical cholecystectomy, the tumor is not grasped, and the gallbladder, even if it is held from areas which are not suspicion of a gallbladder malignancy. And I think similarly, you breach the cystic plate in a lap cholecystectomy when you're doing for an unsuspected gallbladder cancer, but it is preserved when you talk about doing a lap radical cholecystectomy. So I think this is in a tabular form, just telling you that the plane of transection and the tumor manipulation is not there. And similarly, also the risk of bile spillage, because you are not handling so much of the gallbladder or removing it from the cystic plate. So the risk of bile spillage, as we all know, is more commonly when you are removing the gallbladder from the bed. So I think this is the landmark paper of my dear friend, Professor Hahn group, in which they talked about 36 patients. And this is the paper in which a median follow-up of 27 months showing no port site recurrence was a convincing evidence to the world that port site recurrence is not really a hindrance to going for a laparoscopic radical cholecystectomy. And actually, I personally started doing laparoscopic radical cholecystectomy after this paper of 2010, and 2011 is when we did the first case, and I presented in Professor Hahn's one meeting a brief video of that. So, and as you can see, the median range or total lymph node count was 8, that is 4 to 21. And so I think when you talk about laparoscopic radical cholecystectomy, there are two components: the hepatic resection, which is probably more easier to do, and lymphadenectomy. And when there is extensive disease, adjacent viscera resection. So this is just segment 4B5 resection is not that difficult a job for most people who are doing laparoscopic liver resections, but I think it is the lymphadenectomy and taking care of all these group of lymph nodes, as Professor Senan talked about, is very, very important. And I think in Professor Hahn's paper, it was that when you suspected a malignancy and subsequent to the frozen, if you thought that you can go ahead and do a lymphadenectomy, go ahead and do it laparoscopic, otherwise you could convert it. So even in their series, 50% they could avoid doing a laparotomy. So this is just a picture of one of our cases to show that all the lymph nodes along the vessels are removed. And this is a paper, of course, there are several papers talking about lymph node yield. And this is one paper that we published in which we compared the laparoscopic versus open, and the yield was comparable. So, and as regards the follow-up and the survival, or even though this was a small series from Japan, but you can see 152 months, 149 months. And I think subsequently, I'll take you through some of the literature which has talked about that the results are pretty good. So I think we have almost, the literature supports the first 2 points, and I'll more critically look at, does it compromise on the long-term results? And I think this was a very nice paper, again, updated series, Professor Han's group, which was 45 patients. And in fact, they had a fantastic 5-year survival in T1A and T1B, which of course, as it is, has a very good survival, but even in T2, they had 90.2%, and with a median follow-up of 60 months. And this led to in Seoul 2016, which Professor Catherine was also talking about, that we had a consensus meeting which was organized by Professor Han on 10th of September as IASGO World Congress. And in this, we presented, this is a table which I presented of my talk at that time. And at that time, we had 63 patients, which we had done till that time, and with reasonably good results. And so this is just to talk about that. This led to the publication that laparoscopic surgery for gallbladder cancer, and this was an expert consensus statement. And the conclusion was that with preoperative recognition of gallbladder cancer and careful manipulation to avoid bile spillage, laparoscopic surgery does not worsen the prognosis of patient with early stage GB if definitive resection during or after laparoscopic cholecystectomy is conducted. And of course, they said that it is more limited to some centers at the moment, but I think as you will see in my subsequent talk, that more and more centers are now going ahead and doing it. At the same time, they also published a survey results of the expert meeting. And in this, again, this sums up the various series of various people who had done this laparoscopic radical cholecystectomy. This is in a tabular form, and you can see that the results in terms of operative time, blood loss, complications, etc., was reasonably good. And in that, they again said that even though at the moment many centers are doing in selected cases, and there are favorable outcomes in the published reports, and probably this is the way to go. And in near future, there'll be more and more centers going ahead for doing this. And there was subsequently, there was this review article in 2017, which again talked about various series. And you can see that even though in this series, the number of patients was small, but it yielded pretty good results in terms of lymph node yield. If you see 8, 12.6, 13.3, 12.5, and the paper that I alluded to, which was our paper, in which also there was, when we compared with laparoscopy with open, there was not much difference. I think the mean difference was 1 or something. So these are some of the other series, and we are very happy to see that in 2018 and 19 and early part of 20, there are several series from 15 to 75 or thereabout patients, and talking about reasonably good results. Either they will say that the overall survival and disease-free survival is comparable as compared to laparoscopic and open, or the mean lymph node yield is comparable. And this was 65 IGBC patients. And so I think this is, I'm just quickly taking you through these three, 4 papers. Omi et al. Also talked about the similar thing. And all these papers talked about that laparoscopic gallbladder cancer management is the way to go. And this was another paper by Dowsey et al. I'm not going into the details of paper, just to highlight to you that these are 4 or 5 papers which talk about reasonably a significant number of patients with good results. And I think that also gave to robotic, of which we have done 5 cases. And in this Mahesh Goyal paper from Tata Memorial, which talks about the 27 patients that they did by robotic radical cholecystectomy. And these are some of the pictures of our first case of robotic radical cholecystectomy. And you can do achieve a similar result with as for minimal invasive. And these are some of our patients. This is for one of our initial patients who is more than 8 years now and recently came for follow-up. And you have a very good cosmetic result. And now the stage is set that I think laparoscopic radical cholecystectomy is more or less established, and most centers are now moving towards that. But can you advance it to even advanced disease in which adjacent viscera resection or biliovascular resection is required? And so I'll just share with you a little bit of our experience. These are some of the cases in the literature wherein either the CBD involvement is there and they've resected that, or some adjacent viscera. So we analyzed our experience, and I think this is a few months ago. This number has grown a little more. And in that, 11 patients out of 155 had the ones in which we did more than a standard laparoscopic radical cholecystectomy. And these are the results. And we had, these are in a tabular form, 11 patients and single organ resection, which is 3 CBD. and 4 choledochal cysts. In 7 patients, it was done. Double organ, that is CBD and duodenum, or colon and duodenum, in 2 patients, and 2 patients at 3 organ resection. So I think even that is doable. So I think slowly and gradually, as we gain more experience in individual centers, I think more or less you would be able to do what you have been able to do by open method. And these are some of the pictures which are talking about when adjacent viscera was resected by laparoscopic approach. And this is our first patient, I'm not showing the video, in which with a hilar block, we went in and did that. Though that these numbers are selected, and we are at the moment not taking the ones without a hilar separation. But if there's an intact hilum, we would venture that and to do that. So initial cases with limited liver infiltration, now with also gastroduodenal infiltration, with limited colonic infiltration and requiring CBD excision, we have been doing, and gallbladder cancer with hilar block with patent confluence in some of the cases, very, very selective, I would say, and robotic radical cholecystectomy. There were logistical reasons, so we have not been able to push that the manner in which we wanted to, but hopefully over the next few months, we should be able to do more robotic radical cholecystectomy. And at the moment, we have not ventured into doing an extended right hepatectomy for gallbladder cancer laparoscopically, and similarly not HPD, but hopefully in near future, we would be able to do that. So in conclusion, laparoscopic radical cholecystectomy is feasible with adequate early oncological outcome in early gallbladder cancer and selected locally advanced gallbladder cancer patients, which are comparable to open radical cholecystectomy. Minimal invasive approach has the potential to be adopted in the surgical management of gallbladder cancer, fear of early and port-site recurrence notwithstanding, and for tumors needing, in addition to liver resection, lymphadenectomy, and or adjacent visceral resection with reconstruction, minimal access approach can be safely and effectively performed. Thank you very much for your attention. I hope I have kept to the time and not exceeded that, because thank you very much.
Thank you. No worries, Professor, you did not. So thank you for sharing with us your experience on laparoscopic management of gallbladder cancer, Professor. Now for our last lecture for the night. This is on the perioperative adjuvant therapy for gallbladder cancer. So our last, but definitely not the least, speaker for tonight is a graduate of Far Eastern University, Dr. Nicanor Reyes Medical Center. He had his internal medicine residency training at De Los Santos Medical Center and medical oncology fellowship training at St. Luke's Medical Center. He also had gastrointestinal malignancy observership at Peter MacCallum's Cancer Center, St. Andrew's Place in Melbourne, Australia. He is presently the Assistant Medical Director for Quality and Safety, Head of Section of Oncology, and a member of the Training Committee of Department of Internal Medicine at De Los Santos Medical Center, a co-faculty of mine at St. Luke's Medical Center College of Medicine. Ladies and gentlemen, Dr. Maximino Bello III.
Thank you very much, John. As a disclosure, I would like to inform everyone that Dr. Kakas is my boss at the College of Medicine. This will be one of the shortest topic. Probably will take about just 10 minutes of our time, so that we will have more of that in our case discussion. We'll be talking about 2 topics. The first one is neoadjuvant treatment, and this is actually a very easy topic. In the NCCN guidelines, there is actually, for gallbladder cancer only, no preferred treatment. In the North American consensus, let us be clear, they do not have a preferred regimen. However, there are a host of drugs, of molecules that has been identified to be active, and local experience and even international experience in phase 2 trials has suggested that these are active. Now, having said that there is no NCCN guideline, there is actually some data on the role of neoadjuvant treatment. And one of the more modern or recent publication is by a review by Hakim et al., published in the European Journal of Surgical Oncology. In this particular meta-analysis, they look at trials with advanced gallbladder cancer, but these are non-metastatic. They look at, they found eight studies with a total of 474 patients, and 398 received neoadjuvant chemotherapy, and 76 patients received some form of neoadjuvant chemoradiotherapy. Now, the authors in this particular trial, Doctors Hakim Abdul and company, are actually surgeons, and they were actually disappointed with the results because after the chemotherapy or the chemoradiotherapy part, only 50.4% of the patients were considered suitable for surgical resection, of which only 40% underwent a curative resection. That numbers still goes down when we look at the R0 resection rate. So ultimately, about a third of the patient underwent a R0 resection. What is heartening, though, in this particular series is that the survivorship range was from 18 to 50 months. So as compared to historical control, these particular numbers are quite good. Looking at much more well-defined studies, this is a study coming in from our colleagues from India, but this is quite unique is because the lead authors here comes from a hepatobiliary service in a major hospital coming from India. And here they were talking about locally advanced or borderline resectable gallbladder cancer using the so-called TMH criteria. In this particular study, they look at 160 patients. They received some form of neoadjuvant chemotherapy, gemcitabine cisplatin, and gemcitabine oxaliplatin, and they received the surgery. The primary endpoint here was actually the response rate. We could roughly talk about this as a shrinking rate and a clinical response, clinical benefit rate. And it was actually quite high, 52 and 70% respectively. Here now, there was a much more bigger proportion of patients who underwent a curative resection. If you would recall the previous article, only about 1/3, but these numbers is coming into approximately 40%. And these patients who were curatively resected enjoyed a better survivorship outcome. Of course, that was as compared to those who were not resected. Here are the details of that particular study, and I would like to call your attention to the various to the graphs over here showing the survival curve, and over here of the entire group, and over here the blue line over here are those that were resected, and those here that was non-resected. Okay, they were not resected. Surprisingly, in this particular study, they found out that those who were node positive and T3, T4 disease were derived a much more better advantage. Moving onward to adjuvant treatment, okay, it is mentioned here in the NCCN guidelines that the preferred regimen is capecitabine, and it's a category 1 regimen. Of course, there's a caveat here that this particular recommendation comes on the strength of the BILCAP trial, which was not primarily designed for gallbladder cancer. It was primarily designed for biliary tract cancer. However, yet still, despite those caveats, the molecule capecitabine is accepted as a preferred adjuvant therapy for gallbladder cancer. As usual, based on metastatic disease and previous studies, there are a lot of molecules or drugs that has been shown to have activity in these particular disease entities. Now, This is actually one of the earlier meta-analyses on this particular disease entity, and this was published in 2012 by Anne Horgan et al. They look at 20 studies, and this time, these 20 studies was able to accumulate over 6,712 patients, and they were looking at adjuvant treatment. The adjuvant treatment here was either a form of chemotherapy and a form of chemoradiotherapy for biliary tract cancer. What is nice about this publication, there was a subsequent division into whether it is a gallbladder or just a pure bile duct malignancy. In these particular studies, we will talk about the effects of adjuvant treatment in the gallbladder cohort. So in the gallbladder cohort, we had several studies coming in from the United States, Japan, Sweden, and this was quite a good number of studies. Now, we will just concentrate on some of the key effects of these meta-analysis or the key findings of these meta-analysis. Specifically in the gallbladder cohort in terms of survival, we could see here, okay, that there is a benefit for some form of therapy or adjuvant therapy in the gallbladder subgroup based on meta-analysis. If we look at much more specifically on node-positive disease, adjuvant therapy, gallbladder cancer, node-positive disease, the effects is still there, but if you would now see the numbers, the diamond, the center of the diamond clearly favors the experimental group, which is adjuvant treatment. Looking at margin-positive disease, again, gallbladder subgroup, the 4 studies predominantly powered by the Japanese trial now clearly shows a benefit in giving adjuvant treatment in margin-positive disease. Because of these particular results, however, that results were a reflection of studies that was done in the early 2000s. Again, the meta-analysis by that published in the United States were a reflection of earlier studies. They attempted to update these particular adjuvant study, and this was published recently by Ma et al. In the British Journal of Cancer. Here, they look at 10 retrospective studies, totaling 3,191 patients, but this time now, we are now talking about a pure cohort of gallbladder cancer patients. Here, they offered these patients adjuvant treatment compared with just curative intent surgery. Here, the result was, and let me read it to you, there was a non-significant improvement in overall survival with adjuvant therapy compared to surgery alone. However, a significant improvement was observed in overall survival with the chemotherapy arm compared to surgery alone. The greatest benefit of adjuvant therapy was seen in R1, which is consistent with the previous meta-analysis published in the United States. Also, the lymph node positive group and stages and stage 2 and above. However, surprisingly, the benefit of adjuvant treatment was not seen in lymph node negative or RO0 disease. And I think this is just the technical, these are the forest plot. Again, looking at overall population. Again, our population here is a pure gallbladder cohort. We would see that the diamond or the point estimates falls on the left, okay, signifying signifying some benefit for an adjuvant treatment. Here now is a unique breakdown on the specific types of treatment. We have radiotherapy here, chemotherapy here, chemotherapy here, and we would see that the chemotherapy arm, the point estimate clearly falls on the left side, making it confirming the benefit of some form of adjuvant treatment in resected or curatively resected gallbladder cancer. So to summarize, neoadjuvant neoadjuvant treatment, not so much available data. However, moving into adjuvant treatment, meta-analysis has shown that there is a significant survivorship if our patients are offered some form of adjuvant treatment. So with that, I would like to thank you and turn you now over to Dr. John.
Thank you, Dr. Bello, for discussing to us, even with the limited studies with regards with the chemotherapy on gallbladder cancers. Thank you very much. So after all those 6 lectures, I think we have a few minutes to spare for a few questions. If you have questions, please type in your questions at the Q&A or chat box. So I think we have a few questions here. Some were answered. Probably we can run through it, and probably other members of the panel can comment or answer some questions. Okay, so one question here is, in the event intraoperatively the gallbladder is hard, fixed, and highly likely to be gallbladder cancer wherein cholecystectomy cannot be performed and there is no hepatobiliary surgeon, what is the best thing to do? So probably our surgical panelists can give some thoughts here.
Yeah, thank you, John. And I've answered Paolo here. No, it's somebody else. My answer there is if you, first, it's not inflammatory. There's a discovery intraop. It's a mass rather than inflammatory. The likelihood is preoperatively the impression was cholecystitis, and therefore the patient was underwent surgery. Whether it's lap or open, what was discovered is a tumor. And that's my assumption in this case. And therefore, you now turn to yourself and ask yourself, do I have those 3 competencies around to help me out? If you don't have it, what is best for the patient is to terminate the procedure and send that patient to an HPB center. That is what is best for the patient, because gallbladder cancer has a chance for cure. And if that chance was given up by less than what should have been done, then the patient loses the chance for cure. That's my answer, John.
Thank you very much. So it's like stop messing it up and then just close it up, probably refer it to a specialist.
I won't look at it from that point of view. You really have to honestly look at those 3 competencies. Are they around? Remember, the 3 competencies they go beyond the surgeon. There has to be your friendly pathologist, and if need be, go back to the image. Was the image true to you? And then take a look. You may have missed something there. All right. Is there a liver involvement? Are there notes? You really have to go back and then ask yourself, is this something that I can do? Is the team prepared for this? And so on. Thank you.
Thank you very much, Dr.
I think
Alfonso.
apart from the 3 competencies that Dr. Alfonso has mentioned, there's another competency that we sometimes, or a lot of times, we fail to consider, which is perioperative support. So even if you think that you would be able to perform the most aggressive surgery, but post-operatively, the patient deserves critical care, especially when you are going to perform hepatectomy. or a combined hepatectomy and other radical procedures involving resections of other organs. So that is also something that you need to weigh and consider. Do you have the post-operative critical care support? So we have to be very prudent with our decision-making process.
Agree totally, Kathy. Do you have a blood bank? This is very, usually it's taken for granted, but if you don't have one, it's going to be very risky for the patient. Really agree with you, Kathy.
Yes, and it's just very unfortunate that we see a lot of these referrals when they already did partial cholecystectomy. There's already biliary spillage, and some form of surgery has been done, and yet it will not serve any good for the patient. And once the patient has arrived at our institution, we cannot even offer anything much better than palliative care. Patients who have had a very good surgery, or in fact, prior to surgery, high index of suspicion from the scans, and very good awareness and interpretation of the CT. These are the patients who would have a good chance. They stand a very good opportunity to have R0 resection and long-term survival. And in fact, even vascular resections we do for our patients with extended hepatectomies, and they live much more than 5 years. And I'm very sure that we all have seen one way or the other, or at some point in time, when we would think that we are offering the patient some form of palliative surgery by doing a partial cholecystectomy. In reality, we are just upstaging the cancer of the patient and really not offering any good for them.
Thank you very much. I think that is true with having gallbladder cancer diagnosed intraoperatively or postoperatively. I would like to ask the experience of Professor Anil with regards, do you still get cases wherein gallbladder cancer is not diagnosed preoperatively, or almost always you diagnose gallbladder CA even before you do anything to the patient?
Yeah, thanks for asking. Mostly we have primary gallbladder cancer, which are diagnosed preoperatively. But some referrals come in as what the previous question was, that wherein the surgeon put in the scope or opened, and what was thought as benign turned out to be malignant, and they have referred. And it was a prudent decision to refer it, because on the lines as Professor Senon and Catherine talked about, that it's not an ego issue. It is not what you can do by your personal skills, because what is important is that do you have a supportive system which will support the appropriate action that you want to take? Because I think I want to again re-emphasize this, because there might be a surgeon who's trained in a very good center and goes and sets up a practice somewhere else, but your system is not supportive, because by the time you build that up, so please don't, as you yourself, Romaldo, said, don't mess it up. And I think that is very, very important. And in fact, when we compare our data between some of the centers which get a lot of cases in India, like Tata Memorial, Sanjay Gandhi PGI, are probably the 3 centers where more cases come in. And we find there's a big difference, because in Tata, they get a lot of referred cases which are after cholecystectomy has been done and turn out to be incidental gallbladder cancer. And a lot of time, even in the literature, when you look at, incidental gallbladder cancer has been so loosely kind of defined, because by definition, incidental gallbladder cancer is in which you did not suspect preoperatively, intraoperatively, after doing cholecystectomy and examining the cholecystectomy specimen. And these are the ones which are by definition likely to be early stage cancer, as compared to, but unfortunately, in the literature, when you scan any patient in which post-operatively the biopsy has come as gallbladder cancer are put in the basket of incidental gallbladder cancer, and which skews the data, and people draw wrong interpretation from that, because I would think that it would be very, very rare to have a T3 or a T4 gallbladder cancer, which is actually incidental gallbladder cancer. That probably might only be the ones in which there were adhesions which you thought were inflammatory, but it was. Or maybe because depending on where that surgery was performed, the surgeon did not suspect. If it was an HPB surgeon, there is no way a T3 or a T4 lesion, or as Professor Senon said, that probably intraoperatively, like sometimes you have xanthogranulomatous versus a gallbladder cancer, you would have thought about it and thought of taking the help of your frozen section histopathology colleagues. So I think it is very, very important that it is a team approach, and you have to assess not only your skills, and if there is something wanting in your setup, then you build that up before you venture into these a little beyond. I mean, like if I was to talk about in our experience, some of the procedures that we are doing, laparoscopic or otherwise, we wouldn't have done 10 years ago, or we wouldn't have done 15 years ago. I think probably you keep pushing the envelope as you go along. So I think that's just my comment.
Thank you, Professor. So I think it's really preoperative diagnosis or workup is really important. With related to that, there's a question: what are the findings in ultrasound which will prompt to request a CT scan or MRI? So when we are given a reading of a thickened gallbladder wall, do we automatically request for CT scan or MRI? So can we hear some thoughts from Dr. Pilapil?
Thank you for the question. So actually, if you are already suspecting of cancer, so you can request for CT scan and MRI to evaluate the lymph nodes if there is any invasion of the adjacent structures, and to evaluate for peritoneal seeding.
Okay. How about which imaging is best used for involvement of the vessels? MRI, CT scan, or Doppler?
It's still contrast enhanced CT scan, but you have to emphasize triphasic contrast enhanced MRI, because there are some centers, if you don't emphasize triphasic, they would only do portal venous phase. So it's better to emphasize triphasic contrast enhanced CT scan.
All right, thank you very much. With regards to pathology, I think there was a question here. Dr. Mendoza, can pathology differentiate cholangio CA from gallbladder CA or a metastatic one?
If we would be talking about use of immunohistochemistry, cholangiocarcinoma and gallbladder tumor would give us the same pattern of staining or the same phenotype. So this would correlation with imaging and clinical features would play a very big role in this kind of situation. So if in the event that the tumor is extending beyond gallbladder, then that would be the time, that would be the best time for us to use some immunostains. Like for example, if it's approaching or encroaching the liver, then we can use some liver markers to differentiate it from the gallbladder tumor. But differentiating gallbladder carcinoma per se from cholangiocarcinoma, then it would be difficult because the immunomorphologic features would be exhibiting the same pattern. It would be a different story if it's differentiating from liver cancer or hepatocellular carcinoma versus gallbladder carcinoma. We will have stains available to differentiate them. So in this whole situation, the correlation with appropriate imaging and clinical info would really play a big role for us to arrive at the definitive diagnosis.
Yeah, I think that is the problem with hepatobiliary pathology, right? So it's sometimes it's very difficult to differentiate just with plain staining without the immunohistochemistry and also with the clinical and radiological backgrounds of our patients.
Yes.
So We have a question here for Dr. Bello. Is adjuvant chemo recommended for stage 2A R0 gallbladder cancers?
Okay. For stage 2, okay, we would want to ask, are there any other pathologic features of that would give us reason to offer the treatment if you had if you have other pathologic poorly differentiated LVI. Now, to answer that directly, it is common practice, at least for most oncologists, to offer some form of treatment. Remember, most of the clinical studies are centered on T3, T4s. So the T2 is an unknown or a gray area as of this particular time. So we will tend to offer some treatment, yes.
So an adjuvant would be...
Yeah, adjuvant treatment, yes.
Okay, thank you, Dr. Bello. Since we were discussing about T2, T1s, how about a T1A lesion that is on the liver side? Would a plain cholecystectomy be enough? Or if it's on the liver side, we take into consideration doing an extended cholecystectomy? Sir Johns in the panel can answer, please.
Oh, okay. T1A.
On the liver side, sir.
Yeah. T1A, and then intact gallbladder, there's no spillage. Laparoscopic or open, no, I would observe. Survival, general is very high. Remnant, more likely none. The location is something still debatable. Others would go for a 2 cm resection of the adjacent 4B and 5. But most surgeons or most data series that we have seen now, if it's strictly T1A down to the lamina propria, no, just a cholecystectomy intact GB being pulled out. That's my opinion.
But a T1B, that's automatic extended
T1B,
cholecystectomy,
yes.
regardless of the side.
Yes, regardless of the side.
Actually,
Dr.
it's very
Arce?
anything beyond T1A, you need to re-examine. You need to re-examine the specimen. You need to re-examine the scan, the preoperative imaging. T1A cholecystectomy will suffice, and prognosis is pretty good, up to 80%. Most systemic reviews have shown that. The most recent systemic reviews have shown that.
Can I make a comment?
Go ahead, Professor.
Yeah, I mean, as both the surgeons have said, I think I wanted to make a comment that it depends on, as Catherine said, it is very, very important that you are dealing with T1A. So in fact, a lot of times you would not base it. I mean, I would divide them into two. One is that when you are doing surgery and the frozen section says T1A. And the second situation, which is the more common situation, wherein the cholecystectomy has been done and the person comes with a report of T1A. Now, in this T1A, if the report comes with, as Professor Senon said, that you have to have a reliable histopathologist. So you would not go by just one slide report, and you would want to get the blocks from the referral hospital and make sure that it's T1A, because the Yamaguchi's paper that he alluded to, in fact, one of the patients of T1A had metastasis in the subsequent period. And when they went back and looked at the histology, it was actually T1B. So I think it is very, very important that if you are dealing with T1A. So as a question, if you said T1A, yes, nothing else needs to be done. But make sure that as expert histopathologists, and especially RAS and all that, they have seen and made sure that it is T1A. Now, the second thing is that if intraoperatively, which sometimes happens with a polypoid lesion in the gallbladder, if it comes as a T1A, we have to keep it in mind that frozen section is not so reliable for definitely telling you that it's T1A. And considering that the morbidity mortality of a straightforward radical cholecystectomy, laparoscopic or open, is pretty negligible. So you would go ahead and probably give the benefit. This is what our approach recently has been, that if it was from an unreliable center without our getting the blocks, or it is a frozen section, we would go ahead and do a completion radical cholecystectomy. I mean, it may be open to debate, but I think,
I think, Anil, what you actually would advocate is a second look, because without the initial histopath, without the initial findings,
yeah, if you're not sure, yeah.
Yes, we are not certain, and that a second look or an exploration would probably be a good option. You know? And it's really very true that we would, even if the histopath says T1A, we personally, what I really would advocate is, especially when it is a true incidental, I would always go back to the scan, go back and look at the histopath, recheck, and make sure that it's truly a T1A, because it really makes a big difference.
Thank you. With regards to having an incidental gallbladder CA after a cholecystectomy, do you follow any time frame for you to be able to go in and do your extended cholecystectomy?
There's no John, Dodi. There's no
Right, sir.
specific time frame once you have received. If they're usually referred to us, once we receive them, we go back. I think I emphasized this during my talk. We go back to the images, the original images. We go back to the original histopath specimen, and we re-examine them. Along with our friends in radiology, in pathology, you need to be precise about this. And I cannot I'm seconding what Kathy and Anil said. They're very, very critical for you. First, it's the T stage of the original lesion that was seen, not when you saw it. So that will dictate to you the mode of therapy at this time when you saw it. No, there's no particular time. We just move as soon as we can, and then we discuss this with the patient. And of course, as I've said, part and parcel is always what is the context of the patient, particularly if we're dealing with what appeared to be T1A, which is actually T1B, and the patient before you doesn't feel anything. They're looking at a piece of paper.
Thank
And
you,
in
Dr.
addition
Alfonso.
to that, I would, in fact, not really pertaining to the time frame for re-exploration, but to rescan the patient in the shortest possible time, because there were reports, and we have seen them. Even in early stages, we have seen skip lesions where metastasis or liver lesions are not direct extension, but rather metastasis. They were seen beyond the 2 centimeters from the liver bed. So this is already considered as metastasis and not direct extension of the gallbladder tumor. So a rescanning of the patient of the area of the liver would be a very good place to start with, and then decide when your surgery can be possibly done. There are different school of thoughts. There are some that would say as early as 4 weeks. There are some that can go beyond from 8 to 12 weeks, looking at the test of time. So it's until now it's really debated what is the optimal time, but at the minimum, do a repeat scan and assess the patient very well if a resurgery would be really, be either be possible or be necessary. I think Anil,
Yeah,
do you
Professor
have
Anil?
opinion?
Yeah, I think as you rightly said, both of you, that you need to image and stage that is there any tumor, residual tumor, and various other things, how the patient is and other things. But what we follow is that the sooner you go in, the better it is. Because when we analyzed our data, because in this, you don't follow the 6-week rule as most people would talk about. We don't wait. Unlike, because even though it's a redo surgery, but in this, the longer you give the tumor, and especially when there's a residual tumor, more likely it will spread. So when we analyzed our experience, what we realized was that when you waited long enough, when you waited longer, the resectability went down, the magnitude of resection went up, because even to differentiate between what is tumor and what may be fibrosis goes up. So I think that is why the sooner you go in, the better it is. And I think, again, the point is to again re-highlight it, the true versus the incidental tumors that we talk about, because when we analyzed our data, 50% of what was labeled in the basket as incidental gallbladder cancer were actually in which, if you went back to the imaging, the ultrasound, or in some cases the surgeon had asked for a CT scan, that itself means that probably it was misinterpreted and there was a reason to believe that what we were dealing with was a primary gallbladder cancer.
Thank you very much, Professor. So the key is the shortest possible time that you can go back in. That will be the best time, especially if you need to refer your patient.
Yes, counterintuitive to wait. It's counterintuitive and contra good outcome.
Yes. So stop thinking about what you did wrong and move forward and do something better for the patient.
Correct.
So anyway, we have a question again. What about the benefit of intraoperative ultrasound with regards to probably diagnosis of a gallbladder cancer?
Is it diagnosis or extent of resection?
It is not mentioned. Probably
it's very
more
useful for extent of resection.
For
meaning,
resection,
yeah,
meaning it's already a known case.
Yes, it's very, very useful, particularly if you're embarking into an extensive liver resection. And some groups are using it for determining positivity of lymph nodes, particularly in the interaortocaval basin, without the benefit of, in some cases where there is no reliable frozen section or pathologist. But this thing again is controversial. We would not do this in the center we go to. We practice. We make sure that our partners are with us. The multi-specialty groups are with us during this during the management of such cases. So, but the question is it useful? Yes, it's very useful. Intra-op ultrasound. Pre-op ultrasound, we mentioned. No? There are a lot of talks earlier how ultrasound will help us make a pre-operative diagnosis, at least a moral certainty that we might be dealing with gallbladder cancer. And intra-op, yes, it's important because we double check what we saw in the triphasic CT scan. There might be some cases in which we need to be guided, particularly if you're doing resection, complete resection of 4B and 5, and probably even adjacent segments, because you need to be clearly guided on which you might hit some vascular structures that you need to preserve. Thank you.
Thank you very much, Dr. Alfonso. Another question: if the pre-op imaging is indeterminate and intraoperatively the surgeon suspects malignancy, would you recommend outright radical cholecystectomy, or would you attempt to establish histopathology with frozen section?
You're not sure, frozen section of the lesion, and as I've said, look at your competence. You have a reliable pathologist whom you have worked with for some time and who is excellent in HPB pathology. Do a frozen. If it's positive, proceed as dictated. But if you don't have one, the recommendation is, and you're highly suspicious you're dealing with malignancy, What is best for the patient is don't proceed, refer to an HPB center. What that it's a general recommendation.
Yes. I think,
can I just add here?
Go ahead, Professor.
Just that I would allude to that Professor Han's paper. And as Professor Senon said, that depends on whether you can do it or not. But the thing not to be done is that if you're suspecting malignancy, to remove the gallbladder and separate it from the GB fossa, because you will have bile spillage and other things. So either you do nothing and send it to a referral center, an HPV surgeon, or if you thought that you could go ahead and do with a wedge of liver, then you take that out and send it for frozen section analysis. So I think that would be the thing. But I think if there is a reasonable suspicion of malignancy, please don't just do a cholecystectomy. And that's I think the message.
Thank you, Professor. Probably we can come up with two last questions. Can you comment on the Korean study regarding surgery in combination with systemic chemotherapy may be beneficial in carefully selected patients with stage 4B gallbladder cancer? Is anyone familiar with this study?
John, I cannot comment there, please. Sorry.
Okay.
How about Dr. Bello? Have you heard of this study, Dr. Bello?
I haven't heard that particular study, but based on what was published, not that specific Korean study, most authors in non-metastatic disease will offer in borderline resectable advanced diseases some form of neoadjuvant treatment. That's my take on it. I haven't seen the specific paper, but in the NCCN guidelines, they do recommend if you see a locally advanced malignancy, okay, we at least try to offer a form of neoadjuvant treatment. Now, we do not have high quality data for this particular subgroup of patients, so we probably have to check on that later.
Thank you very much, Dr. Bello.
Yeah.
One question. Go ahead, Dr.
I agree with Dr. Bello regarding that, and that is our approach. Basically, when we see a stage 4 gallbladder cancer, we subject the patient to neoadjuvant chemo, and then subsequently, after reassessment, if we think that surgery is possible for this patient, then we proceed to surgery. So we don't have that big a number of patients. Obviously, it is highly selective, but we do have a few of these patients that were eventually resected after very good response from neoadjuvant chemotherapy for stage 4 gallbladder CA.
Thank you.
John, I think I mentioned that earlier, that if the inter-aortic cave lymph nodes are positive, that's considered M1, and therefore that's virtually bad stage. And therefore, what's recommended is don't touch anything yet. You can go for neoadj and see if there is any response. If because the outcome gets to be better if the tumor is sensitive to the chemo, to the neoadj. If it's non-responsive or non-sensitive, or well, you won't. No matter what you do, it's not going to improve the outcome.
Thank you very much, Dr. Alfonso. With regards to the routine opening of a gallbladder specimen, I think
it's a must. It's a must.
There are two things
that I mentioned earlier that's a must for all of us general surgeons. Please, when you take out the gallbladder, keep it intact. Bring it out the body or the cavity, and then please always open the gallbladder without destroying, of course, your pathologist will get angry to you if you squeeze it and you destroy the layers. But you can open it safely away from the lesion if you can feel one, and then take a look if there is any lesion. Those two steps are a must to all surgeons who are doing gallbladder surgery.
Thank you very much. And I think it was mentioned by Dr. Mendoza that we should properly label the patient, the specimen of the patient for proper documentation and for proper reading by our pathologists.
Maybe
So-
can I just say something?
Go ahead, Professor Andy.
Yeah, I think as he very rightly said, that one is no doubt you have to open all gallbladder specimen, and some of the ones which go into the basket at incidental gallbladder cancer are these patients which person has not opened, because when we also studied, and in fact we didn't publish that there were some patients in which there was a 15 millimeter in the gross pathology. They have written 15 millimeter lesion. And obviously, had you opened, you would have seen that it wouldn't have gone as an incidental gallbladder cancer. So I think it is very, very important. And the second point I want to make is that we published this a few years ago when we said all gallbladder specimen must be sent for histopathology. I mean, it may sound it as an obvious thing, but there are few papers, and one particularly from UK, came out to say that it wastes the pathologist's time and saves money if you don't send all of them. And which is when we analyzed our data, because in our country, some centers in the periphery do not send for histopathology. And those had the worst results when they came in, because they were detected only when they came with recurrence as compared to those which come with the histopathology report. So I think it cannot be overemphasized that all gallbladder specimen have to be sent for histopathology, no matter how much you save on money aspect, but saving lives is certainly much more important. Thank you.
Thank you very much. Well said, Professor. So I think we were able to cover all the questions posted to us. Are there any final words from our panelists, from our speakers?
Well done.
Thank you very much. So with that, we would like to thank all our speakers. And may I now call on our friend from Medtronic for a few messages. Ms. Rowena Orque from Professional Affairs and Clinical Education under the Minimally Invasive Therapies Group of Medtronic. Ma'am Orque.
Hello. Hi, sir. Good evening, dear doctors. I hope you can hear me. Before we give our official words from the sponsor, let me extend my sincere gratitude first to the Philippine Association of Hepatobiliary Surgeon Society, of course, led by Dr. Catherine Te, the president, and then Dr. Senon Alfonso, the vice president. Thank you very much to all the speakers, Dr. Kakas, and of course, Dr. Anil Agarwal, our, as mentioned by Dr. Kathy, the authority in gallbladder cancer. Thank you, sir. As mentioned by Dr. Anil a while ago, there is a need for the surgical smoke to be evacuated. So I'm just turning the floor over to our product manager, all the way from Medtronic, India, Mr. Ravi Patel. He will be discussing just an overview of our rapid vacuum evacuator.
Yeah, thanks, Rowena. Yeah, please start the slide. Okay, next slide. Yeah, so good evening, everyone. I'm very pleased to introduce our RapidVac smoke evacuator system, which is compatible with all the electrosurgical unit, including Velilab ESU like ForceFX, FT10, Force Triad, and also it is compatible with any other company diathermy machine also. The main advantage of the RapidVac smoke evacuator is the airflow level, where it can have a suction level of 44 cubic feet per minute or 1,246 liter per minute, and it will be very helpful while evacuating the smoke from the open surgery where there is a scope of smoke to get evaporated in the OR ventilation. Also, the other main advantage is the effective filtration technology, where it utilizes 4-stage filtration, and also filter is having the RFIDs tag so that you can use simultaneously more than one filter, and whenever you insert the filter, it will calculate and indicate the remaining life in the filter. Also, it has the longer filter life of 25 hours, and that is based on the activation time and not on the dependent on the airflow level or the duration of the surgery. So suppose if the duration of the surgery is 2 hours and the overall activation of the electrosurgical unit is only for 15 minutes, then the filter will calculate the life for only 15 minutes and not the 2 hours. Next slide. The four-stage filtration system is an integrated system where there is no requirement of separate pre-filter or post-filter. All is integrated into one system, where the pre-filter captures the larger particles and some fluids, while alpha filter, which is the stand for ultra low particulate air filter, and with the efficiency rating of 99.9995% at 0.12 micron size, it captures the smaller particles. And then there's a third stage is activated carbon, which absorbs the toxic gas and odors, which is generated from burning the tissue. And finally the post filter, which collects and trap the activated carbon of fine particles. And after that, the filtered air is circulated back to the OR. Next slides. So this is one of the frequently asked questions for COVID-19 and smoke evacuation, that should hospital dispose the alpha filter on smoke evacuator after each procedure. So in all the surgical procedures, including those involving a patient with suspected or confirmed COVID-19, Medtronic recommends the continued use of the product in accordance with the labeling, because the design of the device prevents airflow in incorrect direction, like equipment to the patient, and therefore reduce the risk of cross-contamination. As a result, filter may be used until it has reached the end of its life, as indicated in the device. The filter smoke evacuator can be used both in open as well as laparoscopic procedures. We have different tubings for open and lap procedures. Thank you, Ravina.
Thank you very much, Ravi. Now, this one, I just want to show you a full range of our Verso 1 trocars, disposable trocars. And then if you need the wound protector, we have our surgery sleeve. So it has different sizes, extra small, small, and medium. Okay, and also as mentioned by Dr. Anil a while ago, the need for specimen retrieval. So we have our endo bag and our endo catch gold. Now, finally, just giving the floor to my boss as for final words. Let me introduce the head of the Professional Affairs and Clinical Education in Emerging Markets, Asia Pacific. Please welcome calling in from Malaysia, Ms. Linda Su.
Hi, good evening. I hope you all can hear me. It's getting late, and I have to say once again, thank you to the President, Dr. Catherine Tay, Vice President, Dr. Afonso. It is indeed our privilege to continue to collaborate with the key societies such as the Philippine Association of Hepatopancreatobiliary Surgeons, or probably better known as PAHPBS, and really to sustain and continue the training and educational needs for our healthcare professional. Actually, most pertinently, with the current absence of the face-to-face program that we have with this crisis, we believe in Medtronic right now that the virtual platform such as this serves as a critical bridge to continue the learning and skill sets updates. And until then, where we can see each other face-to-face, where it's much more feasible then. But once again, congratulations to the committee. And this is, I've been on this call at the start of this call to now, and has been really informative. Thank you to all the faculties. Thank you to Dr. Anil, all the way down from India itself, to spend this time with us. And well done, and congratulations again to all the committee that organized this webinar. And good evening to you all.
Thank you very much, Linda. Nice to hear your voice.
Take care all the way.
Yeah. Thank you very much.
Kuala Lumpur.
Thank you, ma'am.
On that note, we bring to a close tonight's program. In behalf of the Philippine Association of Hepatopancreatobiliary Surgeons, we would like to thank all our speakers and webinar participants. We also express our gratitude to Medtronic and Telemedicine Network of the Philippines. Good evening and stay safe.
Thank you.
May we just ask the rest who are still here to just take a photo of the, just to take a screenshot. All right. Thank you very much.
Thank you. Good night.
Thank you, sirs, doctors.
Thank you. Bye-bye. See you,
Thank
Catherine,
you.
at some conference near future.
Yes. Thank you so much, Anil. Hope to see you soon.
It's a pleasure. See you
Take care,
soon.
everyone. Good night.
Good night, Dr. Ramonet.